Good day, everyone, joining this first series of a MycoClinic seminar, and a warm welcome to all of you. We will launch this MycoClinic series with a topic in recognizing and managing fungal diseases in HIV patients. And although two clinical experts will each present a case study, we are asking you to be involved as well, because these presentations will be in an interactive case mode, where we will be posing questions to you all joining as attendees. You can submit questions throughout the presentations by the question and answer mode, the button in the lower part of your screen. You can do that throughout the two presentations. We will have a joint question and answer session after the two presentations have been presented. We will also have recordings of the MycoClinic seminar available on our MSc CMM YouTube channel if you want to see them back, or for your colleagues who are not able to attend. So today we have two speakers, which we will be presenting. We will be introducing them later on. And for me, it's really a pleasure to co-share this first MycoClinics with my colleague Anu Chowdhury, who is a professor in medical mycology at the Vallabhbhai Patel Chest Institute at the University of Delhi in India. And for those who don't know me, I am Adilia Warris, a pediatric infectious diseases specialist and a co-director of the MRC Center for Medical Mycology at the University of Exeter. I also want to, because this is the first time of the MycoClinics, introduce very briefly our organizing committee. And you can see that we have a fantastic team of clinical academics around the world: Tom Harrison, Tihana Bichenik, William Hope, Andy Borman, Nilesh Govender, Paul Verwey, Bill Steinbach, Arno Colombo, and my co-chair Anu Chowdhury. So these MycoClinics will be held quarterly, and here you see the dates to be put in your diary to keep the Friday afternoons free to join us for future MycoClinics. I also want to point at another series we run at the MSc Center for Medical Mycology, which is called MycoTalks, which is a monthly seminar series where colleagues, scientists from all over the world present the latest research in medical mycology. And to finish off, I want also to bring this under your attention: a medical mycology trainee seminar series for trainees, organized by a number of very enthusiastic junior colleagues in the field. They also have their regular trainee seminar series, and you will find the links for this to subscribe on our website. So then now it's time to introduce our first speaker, and it's a pleasure to introduce Dr. Ilan Schwartz. He is an assistant professor at the Department of Medicine at the University of Alberta in Canada. He is an infectious diseases clinician and researcher with an interest in emerging fungal infections, immune-compromised hosts, and global health. He attended the University of Manitoba for his medical school training, followed by internal medicine training at Queen's University, and did an infectious diseases residency. During his PhD, which he did at the University of Antwerp in Belgium, he focused on a new fungus found in South Africa, described as Misdiagnosis africanus. And it's really a pleasure to have him presenting one of the interactive cases during this first MycoClinics seminar.
So thank you so much, Professor Warris, and thank you for the organizers for the honor of presenting in the inaugural MycoClinic session. It's a delight to be presenting alongside a hero of mine, Dr. Thuy Lee. And I would just like to congratulate the organizers on this initiative. It really looks like a fantastic resource. to bring together the mycology community. So without further ado, I will just get started. So I have no conflicts relevant to this talk. So I'm going to be talking about a case that I saw in South Africa. This is one of the many townships that are in the shadow of Table Mountain, seen in the distance here. And it also gives you an idea of the degree of poverty in which most residents find themselves. So the patient is a 39 or 40-year-old gentleman who presented to care with a several-month history of loss of appetite, weight loss, fevers, drenching sweats, and a dry cough. On presentation to care, an HIV test was done, and he was found to be HIV reactive with a CD4 count of 9. He was started on antiretroviral therapy, and in context of the symptomatology and the demographics, he was started on empiric TB therapy concomitantly. 6 weeks later, he returned to care, this time with widespread disseminated nodular lesions throughout his skin. These initially started on his face and his trunk, and over the course of several weeks, they basically covered his entire skin surface. And so this is the appearance of the skin lesions. You can see they are nodular papules, some of them coalescing into plaques, and some demonstrate central umbilication. A chest X-ray was done, which demonstrated diffuse infiltrates and nodules. And in light of this, I would just like to open up the first poll. So what is the best diagnostic test at this point? And there's many possible answers. In practice, we do a lot of these things at the same time, but what is the single best test that's going to get us a diagnosis? Is it a histoplasma urinary antigen? Is it a mycoathletic or a TB fungal blood culture? Is it a skin biopsy for histopathology and fungal culture? Or is it a lumbar puncture for cell count, fungal culture, and cryptococcal antigen testing? And once we have about 50 choices, we can close the poll. Okay, so 73% of you said, let's go where the money is and let's get a skin biopsy. And this is absolutely 100% the correct answer. So a skin biopsy was done. This is the GMS stain. And you can see these small yeast-like cells, about 3 or 4 microns in size. They are spherical to ovoid, and some demonstrate single narrow base buds. Now, a histoplasma urinary antigen test was also done. This is the IMI EIA kit, and it was strongly positive with 12.0 nanograms per milliliter. Anything over 0.5 is considered positive. Now, the skin biopsy was sent for fungal culture, and at 4 weeks, this is the growth that occurred at 30 degrees on the sabro-dextrose agar. And the microscopic appearance of the mycelial form is shown here. So this brings us to our second poll. So what is the most likely diagnosis? Is it histoplasmosis, sporotrichosis, blastomycosis, or emergomycosis? Okay, so 46% of you said histoplasmosis, 45% said something called emergomycosis, and I presume many of you are confident I didn't just make that up. Several said sporotrichosis and a few said blastomycosis. So let's have a closer look. So shown here is the mycelial form of this fungus. This is from a different patient isolate. And this is in comparison with the different dimorphic fungi that were thought to be endemic to South Africa at the time. So you can see that although clinically this case is indistinguishable from progressive disseminated histoplasmosis, the mycelial form really is not consistent. We don't see these nice macroconidia or microconidia associated with histoplasma. Sporothrix schenkii has clusters of conidia that appear quite different to this mystery isolate. Now, if we look at Blastomyces dermatitidis, this is the classic form of the fungus that causes blastomycosis, and you can see it has these classic single terminal conidia that characteristically are described as lollipops. But this is what we thought was in South Africa at the time, although we have since clarified that in fact, cases of blastomycosis in South Africa are not caused by Blastomyces dermatitidis, but in fact are caused by two species that we recently described. Blastomyces percursus, which is shown in the upper panel here, comprises about 2/3 of cases of blastomycosis in South Africa, which by all measures is a rare disease. And on the bottom is Blastomyces emzansii. And you can see actually the florets of conidia that come out from secondary conidia are actually quite similar to the mystery isolate. But this is really, this is misdirection. And this is just a confusing fact that we learned later. In fact, this new isolate was sequenced by Professor Govender and colleagues in 2013. This is a phylogenetic analysis based on concatenarized data for 5 different genes. And what they found is that these isolates listed here as the JX39, etc., were quite different from histoplasma, and they were quite similar to something called Emonsia pasteuriana. And so this was described in 2013 in a very high-profile publication by Chris Kenyon, Nilesh Govender, and colleagues as an Emonsia-like organism that was causing a disseminated mycosis in South Africa. We've since clarified some of the taxonomic relationships between these organisms. And I see among many attendees is Andy Borman, who is also central to this effort. And what we now know is that the fungi previously described as Emonsia are actually a heterophilic group. They're not actually closely related at all to one another. And so this has led to some confusion. In order to clarify this, we described a new genus to encapsulate these organisms responsible for disseminated mycoses in immune-compromised patients. And in the wake of this NEJM paper, there have been a number of retrospective analyses of global collections, and we have indeed identified a number of similar isolates around the world. And so in light of this and the apparent emergence, this has been dubbed emergomyces. Now, it's unclear to me how much of this is a true emergence of a de novo organism, or whether this is just a refined recognition based on improved molecular identification techniques that became available. As I showed you, based on the morphology, the organism that causes emergomycosis is distinct from histoplasmosis, but our best guess is that previously, especially in settings of imperfect mycological facilities across Southern Africa, that many of these cases would have understandably been misdiagnosed as histoplasmosis. So in 2015, we identified 52 cases across South Africa. This is through a passive laboratory surveillance in partnership with Nilesh Govender and his network of public laboratories across the country, in addition to one of the two main private laboratory networks across South Africa. And so we found cases of emergent mycosis. We then, at that point, we're calling it emonsiosis, across the country. The majority were identified in the Western Cape, but we think that this represents a referral bias. Now, if you look at the distribution of cases in the Western Cape according to the sector of care, now in South Africa, there's a two-tiered healthcare. There's the private hospital system, which you can access if you have private insurance, and there's the public hospital system for everybody else. Based on the epidemiology and the demographics associated with advanced HIV in that country, we would expect the vast majority of cases of emergent mycosis would be associated with the public hospital system. And so in the Western Cape, we see a ratio of about 10 cases in the public sector for every case in the private sector. And that seems about right, according to what we would expect. The reason I point this out is because in the rest of the country, 3/4 of cases were diagnosed in the private sector. And so what this suggests to me is that in actuality, the number of cases that are underdiagnosed in the public sector are quite substantial. So really, this is likely the tip of the iceberg. Now, in our series, all patients were immune compromised. Of the 52, 51 had advanced HIV with a median CD4 count of 16, and the 52nd patient was a renal transplant recipient. 87% of patients where x-rays were obtained, which was the vast majority, did have abnormal chest x-rays. Typically, these appeared as diffuse infiltrates and nodules, although in some cases we did see consolidation, pleural effusions, and hilar lymphadenopathy. The vast majority of patients had skin lesions, and this could represent a diagnostic bias that we were only making the diagnosis in those patients in whom accessible lesions were apparent. But even in patients in whom the diagnosis was made from other tissue, like from blood culture, from microathletic culture of either blood or bone marrow, many of these patients did subsequently develop skin lesions. Now, these typically appeared as plaques or papules, although in some cases they took other forms. Sometimes the oral mucosa was involved, as shown dramatically in this case on the bottom right, in which there was erosion through the palate. So in a follow-up study, we identified cases of patients with advanced HIV, defined as a CD4 count of less than 50, who presented with skin lesions of less than 6 months duration. And so we identified these patients prospectively. We collected skin biopsies, and we ran a number of diagnostic tests, including histopathology, fungal culture, and in most of the cases, we also did urinary histoplasma antigen. I'll show you those results in just a moment. And the reason I'm showing you this slide is just to highlight that the cutaneous manifestations are really difficult to distinguish from other etiologies. So in the top row are cases of emergent mycosis. You can see this is our patient that we presented on the left. In lighter skin, this can appear as red papules coalescing to form these crusted plaques, but they can appear as vesicles as well. The one that is second to the right shows more of a macular appearance, and these kind of ulcers of various age shown on the very right. Now, in contrast, patients with sporotrichosis, shown in the red border, and histoplasmosis, shown in the blue border, were clinically indistinguishable. And it should be noted that other etiologies that were not fungal disease also were very difficult to tell apart. You can see a case of syphilis shown in the purple, of cutaneous tuberculosis in the bottom right in the yellow, and these ones in between were non-specific cutaneous eruptions of advanced HIV. And so this really emphasizes the importance of skin biopsy. In our 52 patients, we looked at survival according to whether or not the patients had skin biopsy. And what we found is that skin biopsy was very strongly correlated with survival. And so this is because in patients who were subsequently diagnosed with emergent mycosis who did not have skin biopsies, this was usually a diagnosis that was made weeks or sometimes months later when blood cultures came positive for a fungal infection. And in many of these cases, the patients at that point had been lost to care and did not receive treatment for fungal disease. So it was less important to distinguish what type of fungal infection a patient had, but important to identify, in fact, that the patient had a systemic mycosis. Now, the histopathology of these, the yeast-like cells in emergomyces are indistinguishable from histoplasma. And so again, this is likely how this disease was missed for so many years, buried amidst cases of histoplasmosis according to histopathology. So emergomyces on the left, histoplasma on the right. So our patient reacted strongly to the histoplasma urinary antigen, and we systematically studied this. This was led by Tsadisa Mapanga and Nilesh Govinder's lab. And so of 18 patients with emergent mycosis who had urinary histoplasma antigen tested, 8 or nearly half were positive. So this suggests that the test can be helpful in ruling in a diagnosis of a systemic fungal infection. It doesn't tell you whether it's histoplasmosis or emergent mycosis, but the negative predictive value is very poor, and it's insufficient to rule out a diagnosis of emergent mycosis in a patient in whom the diagnosis is suspected. Now, in our series, 3/4 of patients were treated initially for tuberculosis on empiric bases. Now, 1/4 of patients were undiagnosed, and so most of these eventually died. So a 1/4 of patients died without being diagnosed with a systemic mycosis and without having received any adequate antifungal therapy. In total, about half of all patients died. The most common misdiagnoses of the skin lesions were a entity that is very common in HIV-infected patients in South Africa, in Africa in general, but is considerably less common elsewhere in the world, called papular protic eruption of HIV. Lesions were also frequently misdiagnosed for varicella and Kaposi sarcoma, and often they were also explained away within the context of TB without actually pursuing a tissue diagnosis. So in terms of antifungal susceptibility, this is work again led by Tsadisa Mapanga in Nilesh Govinder's lab. And so what we can see is that the MICs for newer azoles, itraconazole, voriconazole, and posaconazole, are quite low, whereas fluconazole is more variable. And we have seen a number of isolates with MICs above 16. Now, it's important to note that there's no clinically validated breakpoints for this disease. As with other dimorphic fungi, the echinocandins and flucytosine are inactive, and amphotericin B does seem to retain activity. Recently, and this is work that was co-led by my co-presenter, Dr. Lee, a effort was made through the European Confederation of Medical Mycology to create global guidelines for endemic mycoses. And so what was really exciting is that this included, as a subsection, emergent mycosis. And so this was the very first time that there were clinical practice guidelines. But the fact is that these recommendations are based on very small case series and anecdotal data, most of which I presented to you here. Now, the recommended treatment is amphotericin B for 10 to 14 days, preferably liposomal, but this remains unattainable in much of South Africa. And the response to amphotericin B is quite dramatic. And so shown here is a patient at day 0 with the papular cutaneous eruption, and on day 5 and then day 10. And you can see these skin lesions literally melt away in front of your eyes. And so it's really a very gratifying disease to treat. At least that's the case in some patients. Now we know that about half of patients are diagnosed soon after starting antiretroviral therapy, between 2 weeks and about 2 months of antiretrovirals, suggesting a unmasking iris or immunoconstitution inflammatory syndrome. Now, in contrast to histoplasmosis, paradoxical iris, or in other words, worsening of disease that was previously well controlled with an increase in CD4 count, is uncommon in emergent mycosis. But there is one case that is worth illustrating for you, and this is one patient that we followed in 2016. So this young man presented, like many do, with cutaneous lesions that started after initiating antiretroviral therapy, which itself was started because of non-specific B-type symptoms. So soon after antiretrovirals, he developed these papular and plaque-like lesions on his face and to a lesser extent elsewhere on his body. And he had a very hyperkeratotic lesion on his left nair. On biopsy, there's an absence of inflammatory response seen on the H&E stain. And then in panel C, you can see there were abundant yeast-like cells seen on the GMS stain. Now, 8 months after treatment, he received induction therapy with amphotericin B, followed by itraconazole. He developed these verrucous papular lesions on his nose, and they really like coalesced to form these really fleshy lesions. Basically, they replaced his whole nose with this kind of this warty appearance. Now, on a biopsy, he had a very exuberant inflammatory response shown in panel E, and there were several inconspicuous yeast-like cells, but certainly far less than on the initial stain. He was treated with a reinduction of amphotericin B, continuation of itraconazole, and corticosteroids. And he had dramatic improvement in the skin lesions, which I think is largely attributable to the steroids. So as I alluded to earlier, similar cases have since been identified across 4 continents. These are caused by very closely related but technically distinct species. So Emergomyces africanus has been diagnosed throughout South Africa and is now recognized to be the most common endemic mycoses in the country. Cases of Emergomyces pasteurianus, and this was that initial species that was first described in 1998 as Amansia pasteuriana, has since been reclassified. So Emergomyces pasteurianus has been diagnosed in much of Europe, in several countries in Asia, and in several countries in South Africa, in Africa, both South Africa and Tanzania. Emergomyces canadensis has been diagnosed. I'm aware of at least 8 cases. Most of them have occurred in western parts of the continent, including Saskatchewan, Alberta, Montana, New Mexico, Utah, and there have been additional cases that we haven't received geographic information about. And then there are two outliers that have only been described from single isolates, Emergomyces orientalis in Asia and Emergomyces europaeus in Europe. Now, as part of my PhD, in addition to describing clinical aspects, we also evaluated the ecological niche of this organism. And so we do know a little bit about it. We know that the mold phase, like other endemic mycoses, exists in an environmental reservoir in the soil. We were able to detect the organism by PCR in a third of soil samples from across the country, and this included a range of habitats. Now, those conidia from the mold-like phase get aerosolized, and in fact, we can detect the DNA of the conidia in the air in the Cape Town area in 10% of all days across the year. These become inhaled by mammals, and so far we've only proven the presence of emergomycosis in humans. They undergo transformation to yeast-like cells, and they disseminate throughout the body in macrophages, primarily to the skin in susceptible hosts. Across the world, almost all cases of emergomycoses have been in advanced immune-compromised patients, and to date, unlike histoplasmosis, we haven't seen cases in immune-competent individuals. So in summary, emergomycosis is the most common endemic mycosis in South Africa. It remains widely underdiagnosed. And it's important, if we can draw a lesson from this saga, to keep an open mind to the possibility of new pathogens when things don't quite make sense. And so, there's a lot of opportunities still for discovery in mycology. And one of the most important lessons here is that it's critically important to biopsy skin lesions in immune-compromised patients. And so I'd like to close by thanking my collaborators on these studies. And as always, I close by thanking my family, shown on the left in South Africa a few years ago, and on the right, this was just last week, thanks to the miracle of vaccinations, reuniting with their grandparents for the first time in 2 years. So again, I'd like to thank the organizers, and I look forward to your questions after Dr. Lee's talk.
Thank you, Ilan. I think Anu is going to take over and introduce our next speaker.
Thank you, Ilan, for such a fantastic talk. Thank you very much. And thank you, Delia, for introducing our first speaker and giving my kind introduction. So here, it's my extreme pleasure to introduce our second speaker. She is a very renowned, eminent physician epidemiologist, Dr. Thuy. She is an associate professor of medicine and associate professor of molecular genetic and microbiology at Duke University. She leads an array of international groups spanning Vietnam, China, and Myanmar, and her main research focus on reducing morbidity and mortality in patients with advanced HIV disease. She's also associate director of the Duke Center for AIDS Research. And there her research focuses mainly on development and testing of novel diagnostics and therapeutics for teluromycosis. She serves on numerous WHO treatment guidelines and review committees on global HIV management. She's presently leading teluromyces guidelines for NIH, CDC, ITSA guideline committee for HIV-associated opportunistic infection. And she holds several positions, editorial positions in scientific journals, including Medical Mycology and PLOS Neglected Tropical Diseases. It's my honor and extreme pleasure to introduce her. And now she's going to deliver a second lecture. Thank you very much. Over to you, Thuy.
Thank you so much, Anu, and thank you everyone for signing on and listening to to our talk. It's such an honor to be able to contribute to MycoClinic. I'm going to share with you today our experience of about 2 patients who with HIV with a convergent management strategy. So the first case is a 35 years old gentleman with histories of HIV diagnosed in 2008 on tenofovir, lamivudine, and efavirenz. He's a construction worker with a history of injection drug use from Ho Chi Minh City. He presented to our hospital for tropical diseases in Ho Chi Minh City in 2018 in July with fevers, nausea, and vomiting. 2 months prior to this presentation, he was recently treated with TB acnitis, so completed 9-month therapy. A month later, he was switched from first-line antiretroviral therapy to second-line therapy with a lopinavir-ritonavir regimen due to treatment failure, and his CD4 count at that time was only 10 cells per millimeter square. And 2 weeks prior to this admission, he was hospitalized for fevers, very similar symptoms, kind of non-specific symptom. He had a conventional diagnostic workup, including imaging, cultures, and everything was negative. He was treated empirically for bacterial sepsis with broad spectrum antibiotic and was discharged. So he presented again with similar symptoms as fever and non-constitutional symptoms. On physical exams, he had a fever of 39, vital signs are otherwise stable. His exams are significant for confusion. He does have some shallow, non-tender ulcers on the hard palate. He has cervical lymphadenopathy up to 2 centimeters. He had hepatosplenomegaly and no skin lesions. He had a pretty extensive workup for Vietnam. He had pancytopenia, moderate, hemoglobin of 11, platelets of 43, white count of 2.6. He had transaminitis, mild. Blood smear was negative, no parasites, no blood cells. His sputum AFB smear and experts were negative. Chest X-ray was normal. Abdominal ultrasound show evidence of hepatosplenomegaly consistent with the exam. He had lymph node aspirate in the neck that was AFB negative, and cultures show no growth. He underwent a lumbar puncture for his confusion, and the cell counts and chemistry was normal, as well as the Indian ink for cryptococcus, and his CSF culture was no growth. He also had stool cultures that show no growth, and blood cultures, 3 sets with no growth. So he basically had a negative, pretty extensive workup for our standard of care. And he was started on broad spectrum antibiotic, this time with carbapenem regimen, and he was not improving. So just pause there for a second and moving to the second patient. Our second patient is a 28 years old gentleman with histories of HIV diagnosed recently, 2 months prior to his presentation. He was a university student. He was an MSM, men who have sex with men, who lives in the central highlands of Vietnam and go to university in Ho Chi Minh City. He presented in 2019 in May with worsening fever, fatigue, exertional dyspnea, and weight loss that has occurred over a 3-month period. So 3 months ago, he was diagnosed with HIV due to extensive weight loss of 10 kilograms. He began antiretroviral therapy at that time, and his CD4 count was 19 cells. A week after starting antiretroviral therapy, he developed fever, fatigue, and shortness of breath, and this symptom sort of intermittent, not bad enough to be hospitalized. He was seen as an outpatient settings in HIV clinics, and they did the workup, which include sputum smear, chest X-ray, and they did blood cultures, and that was all negative. But he continued to have intermittent fever, fatigues, and progressive dyspnea and weight loss. So that's how he presented to us. On exam, he had fever, 38 vital signs are otherwise normal. He had profound cachexia, hepatosplenomegaly, no skin lesion, no lymphadenopathy. On diagnostic workup, he had pretty severe pancytopenia with Thuy count of 0.9, hemoglobin of 8.2, and platelets only 21. He has transaminitis, blood smear was negative, sputum smear for AFB and expert was negative, chest x-ray was normal. He had an abdominal CT that showed hepatosplenomegaly and intra-abdominal lymph nodes, 1 to 2 centimeter, but no localizing lesions. Again, blood culture was negative, so very similar to the other patient. He was started on broad spectrum antibiotics, but no response. So case summary here, we got 2 patients with advanced HIV disease, and they both show up with subacute onset of fever and constitutional symptoms, and they both underwent negative workup. The first patient was hospitalized 2 weeks prior with negative workup, and the second patient had a negative workup as an outpatient. On presentation, both of them had pancytopenia, hepatitis, hepatosplenomegaly, lymphadenopathy, the first patient in the neck and the second patient in the abdominal area. They had no localizing lesion, no skin lesions, and nothing specific on imagings. And they have extensive cultures from sputum, blood, stool, lymph node, CSF for patient 1 and patient 2, sputum and blood were all negative. So these 2 patients are similar in that they have this triad of fever, pancytopenia, and hepatosplenomegaly, as well as splenomegaly. So there is an acute and subacute process infiltrating the reticular endothelial systems, as well as the hepatopoietic cells. And there's actually not many, there's many things that can cause these things in combination, but separately, but in combination of the triad or quadruple system like this, there's actually not many things that cause this. So our differential diagnosis is actually not huge. And when you think about the differential diagnosis in terms of the epidemiology, I apologize for my PowerPoint slide, keep going up, and I don't know how to do this. It does this on Zoom for some reason. But anyways, in terms of the probability, in terms of probability, mycobacteria is number 1. And with that, TB is the main reason here. And NTM also can cause this as well. And then the next category is fungal infections, right? So in Southeast Asia, we would be worried about telomycosis, and we talked about that very shortly. Histoplasmosis is also present in this part of the world, and it's very much under diagnosis. Emerging mycosis, Dr. Schwartz mentioned, was diagnosed in China. We've never diagnosed a case in Vietnam, but there's no reason why it wouldn't be. And I think that it's just been probably under diagnosis. So is on the differential diagnosis. Cryptococcosis as well. And then you got bacterial processes, and I would name a few. Salmonellosis can do this, Bartonella, Brucella, and Rhodococcus would cause this sort of triad symptom. And then don't forget malignancy, leukemias, the lymphoma, the Langerhans cells, histocytosis that can cause this sort of infiltrative process in the bone marrows and reticular endothelial systems and cells. And so these are differential diagnoses, but when you think about the probability, bacteria much less likely, because Salmonella, Bartonella would have grown on cultures on multiple times and would have been adequately treated with broad spectrum antibiotic. Brucellosis, we don't see very frequently. We don't make diagnosis, and the patient doesn't really have that sort of risk factors. So is Rhodococcus, usually risk factor involving people who are working with animal horses in general. And so we put that lower on our list. In malignancy, obviously much more rare in patients with advanced HIV disease. So that leaves us with mycobacteria and fungal infection being the highest on our differential diagnosis. So I'm going to ask you to vote here, and would be the question is, what is the appropriate next step in management in your clinical settings? Obviously, you are coming from all over the world, and I want you to just pick multiple choice here. Whatever come to your mind that you could do next on these patients, whether you're going to get a urine lamb test for TB, you're going to do mycobacterial blood cultures and fungal cultures, you're going to do a fungal antigens or PCR testing, you're going to do a bone marrow biopsy, or you're going to empirically treat them for tuberculosis, or you're going to empirically treat them for antifungal therapy. So I'll give you a minute to answer these questions. And this is a multiple, so you can click multiple choice. Okay, wow, all right, excellent, look at that. Okay, so look like very few, less than 15% of people would empirically start therapy, and they would diagnostic, and look like everybody want all these diagnostic, if possible. And bone marrow biopsy and mycobacterial blood cultures and fungal cultures, as well as antigen tests, would be highly desirable. So what did we do? We don't have urine lamb tests in Vietnam. Unfortunately, that's not being procured by the country, not available. So we don't routinely do mycobacterial blood culture and fungal blood culture at our hospital. And this is, I hope will change with our study very soon. But presumably, if we do these things, let's say urine lamb test was negative and blood cultures will take some time to cook. So what about fungal antigen and PCR testing? So indeed, we did do that because we have the capacity to do that in the settings of clinical study. So these patients actually participated in a prospective clinical study evaluating antigen diagnostics. And this is a diagnostics and immunoassay that target MP1P, which is a telomyces-specific fungal protein being expressed in the cell wall and released in abundance in the circulation. So you can actually catch it in the urine and blood of the patient using monoclonal, polyclonal antibodies. The assay was developed by my colleagues at the University of Hong Kong, Professor Ki Yuan and Jasper Chen. We validated this assay in a retrospective study, large, involving close to 400 culture-confirmed telomycosis and non-telomycosis control. And we found that even in a sample that is in the freezer for many years, the sensitivity for diagnosing telomycosis was 86% compared to blood culture of 72%. So superior to culture, and this takes 6 hours to perform. It has quite high specificity, 98%, and a good accuracy, meaning an ability to differentiate disease from non-disease of 96%. So we did this as part of a study. These patient was enrolled in our prospective cohort to validate this assay with prospective follow-up over 6 months. Patient 1 had OD value in the serum plasma and urine all higher than the cutoff of 0.5. So it's patient 2. And you could see here in the urine, the OD value is actually the highest for both patients. So in the study, we actually stipulate that the patient who are antigen positive but culture negative should undergo bone marrow aspiration biopsy if they have evidence of cellular impairment. So, this is not conventionally done in Vietnam. It's considered very invasive, particularly with patients with advanced HIV disease, low platelet counts. So there's certain risks involved, and this is not being done routinely. But we did this as part of our studies. And so the bone marrow aspirate was performed on both patients, and both was positive. As you can see here on the bone marrow smear, these yeast-like organism that are dividing by binary fission. You could see the midline septum in the arrow bar in some of them here. So Talomyces is the high on the differential here because of the exact feature of binary fission. So Talomyces is the only, actually only fungus that divide by binary fission. There's a couple more, but this is the only yeast that divide by binary fission like a bacteria. So if you see this, that is Talomyces until proven otherwise. Otherwise, the size and shapes are quite similar to histoplasmosis, histoplasma and Emotomyces. Another thing, features of this is that it's a dimorphic pathogen, right? So it's a mole at room temperature 25. And a unique feature of this is on the plate, it will produce a very bright, diffusible red pigmentation as you see on this plate here. And that is really Talomyces until proven otherwise. We do not see Talomyces without red pigmentation. And so, you know, that's very important for the morphology. And then under microscope, they look very similar to Aspergillus and other the mole. And then at 37 degree, it grows as a yeast. It doesn't produce red pigmentation. And under the microscope, you could see this yeast dividing by binary fission. So in terms of patient outcome, number one, patient who started on amphotericin B deoxycholate for 1 week, he needed to be switched to itraconazole due to elevated creatinine, and he was discharged home after 1 month of hospitalization. Patient 2 was treated with deoxycholate ampho B. He improved initially, but then developed sudden onset of severe abdominal pain and distension. He had free air in his abdominal X-ray and developed septic shock due to perforated viscus and passed away. Unfortunately, we think that he probably has some other process going on in the abdomen that was not picked up, and whether that be Talomyces or TB or other things, but he unfortunately passed away. So just very brief now, in the next 10 minutes, going through the review of the literature of Talomyces. So as you see in this global map, Talomyces is one of the 7 endemic mycoses of medical importance, and they are similar in that they are dimorphic. They can infect both immunocompromised and immunosuppressed patients, and they're geographically restricted. So for Talomyces, it's only endemic in Southeast Asia. It is in the environment, so it's a soil pathogen, and it exists in the highland area with high moist, humid type weather. And in the highland area, you got bamboo rats in Southeast Asia that live under the ground, they burrow under the ground. And these bamboo rats, the 4 species, all of them have been shown to carry Talomyces in their liver, spleen, and lungs without being sick. So they are the other host, non-human host of Talomyces. And you could make an argument that they may be also a reservoir, an animal reservoir, to help amplify the pathogen, because the animals are not even sick and they carry the pathogen and spread it as they move to different plantation as they feed. And humans get infected through inhalation through the air upon travel to these regions. In terms of disease spectrum, we see the advanced disseminated disease in patients with advanced HIV disease and profound immunosuppression. There's also localized infections that are much more chronic in nature, that can happen over months to years in non-HIV immunocompromised hosts. And I reckon that we probably have an acute form of infection, acute pulmonary form of infection that we don't recognize in healthy individual. And the only reason we don't know about it because we don't have a diagnostic to test for that. So maybe we just completely not recognizing this form of disease. And that's why I think there's need to develop diagnostic that are host-based diagnostic to really understand the full spectrum of this disease and understand how many people have developed latent infections so that we can develop appropriate public health intervention. In terms of epidemiology, we know that it's highly associated with HIV, and this just to show you the very nice temporal relationship between HIV and telomycosis in Thailand, in Vietnam, and in China. Telomycosis account for up to 16% of HIV admission in this large case series from Guangxi province in China. Of 8,000 patients hospitalized, telomycosis made up 16%, and the mortality was 50% by 90 days. And it's the highest mortality compared to non-telomycosis causes of death. We did this burden estimate studies, and we are still trying to put this together and publish this, but we did this systematic review of the literature from the first case in 1964 to the end of 2018, and we able to identify 24,000 reported cases in 33 countries to date. 90% of patients are HIV infected, with China, Thailand, and Vietnam being the highest burden countries. And if we estimate it based on just AIDS, the incidence of AIDS alone, the 17,000 cases and close to 5,000 deaths occur yearly. And again, this is culture-confirmed disease in which we know is only a tip of the iceberg. And so this estimate is totally underestimated. And we, based on the incidence, rising incidence of AIDS in certain places in Southeast Asia, including particularly Southern China, we estimate that the incidence of telomycosis will increase by 2025. So this just to show you the type of non-HIV immunodeficiency condition that has been reported in association with telomycosis. This occurs in children and in adults with primary immune deficiency and secondary immune deficiency. As you can see, this is an extensive list, and not just predominantly T-cell defect, but you can also see emergence cases that were treated with the novel anti-CD20 monoclonal antibody and kinases inhibitor, which you think that more involved in B-cell suppression than T-cell. So it is probably much more complex than we think, but most likely a T-cell driven disease. Another thing I want to draw your attention to is that we begin to see telomycosis emerging in sort of non-traditional immunosuppressed hosts like diabetes, cirrhosis, COPD, and people with all pulmonary TB. So not just malignancy and autoimmune disease, but we do see them in other sort of chronic medical condition as well. Now, the current diagnosis is unacceptable. The median time to diagnosis is 3 weeks and can go up to 24 weeks. And this is data from a clinical trial that we conducted in Vietnam of recruiting 440 patients. These patients, like our cases, usually present with multiple hospitalization for fever of unknown origin before we make the diagnosis. And in this trial, 7% of patients died before the diagnosis was made. And positive culture was only 70%. Mortality doubled from 24 to 50% if the diagnosis is delayed, and 100% if it's misdiagnosed. Mycology culture and expertise, as you know, are not widely available, and we're working very hard to change that with our with our work to show evidence that we should do more blood culture, fungal culture to improve diagnosis. So what do we have in terms of non-culture-based diagnostic? There's extensive histories of PCR diagnosis, and recently with real-time PCR diagnosis, there's several assays being developed, one of which is our assay that get up to a sensitivity of 88%, and we validated in 133 culture-confirmed cases. So this is quite good, and specificity of PCR is excellent because it's basically a very specific molecular diagnosis. So this is exciting area in development that we hope to roll out in clinical care as soon as we can. Immunoassay is also another excellent way to diagnose, and there's a long history of that. Most recently, there's 2 monoclonal antibody-based antigen detection assay, one that I just mentioned, the MP1P, being used in the studies. We also recently finished our prospective validation study for this assay, enrolling 500 patients with CD4 count less than 100. These are symptomatic hospitalized patients that was admitted in our hospital from January 2018 and December 2019. The 2 patients that I presented was part of the studies. And long story short, 15% of patients were Blastomycosis positive by culture and by diagnosis over 6-month period. 85% of them was diagnosed by culture during their index hospitalization, and 12 of them were antigen positive, but later on developed Blastomycosis by culture during the 6-month follow-up. So overall sensitivity for this antigen compared to the whole culture-based diagnosis over 6 months was 97.5 when we do this in real time. So it's excellent sensitivity. Specificity in this particular population was very good as well at 96.5. So I think this is outstanding result. Another thing I want to mention is the urine performed very well. Even by itself, the sensitivity is 95%, specificity is 98%, and performed better than sera and plasma. So in the 12 patients that I mentioned in this cohort who are antigen positive but culture negative, they develop culture positive disease over a period of 1 to 16 weeks. So as you could see, an antigen test can pick up disease early. We could probably even pick up earlier if we do this in outpatient settings in patients starting antiretroviral therapy, not waiting for them to come in with symptoms. Even with symptom, we can pick up disease 4 months before disease become positive, and that I am certain that will change the course of disease in these patients. So that is very important intervention to push forward. So this particular assay has also been validated. My colleague, Dr. Linghua Li in Southern China, and she found in a cohort of 236 patients entering care with advanced HIV disease, Blastomycosis antigen was positive in 20% of patients compared to the 3.4% of cryptococcal antigen. So Blastomycosis again is very endemic in certain places in Southeast Asia, and it requires a lot of attention from the world community. And almost all of these antigen positive patients went on to develop culture positive disease. What about screening asymptomatic people in clinic without symptoms? This study done some time ago in 2015 by my colleagues from the University of Hong Kong, screening patients in Guangdong, 8,000 outpatients. This is a serum bank, so it's not a prospective study. And they found a prevalence of TM antigenemia of 9.4% with different CD4 count level, and the prevalent go as high as 24% in people with CD4 count less than 20, less than 50. In Vietnam, we recently did another study that show a prevalence of TM antigenemia of 4.2% in 1,000 outpatients starting therapy with CD4 count less than 100. And these patients who are antigen positive have independent, the antigen positivity, was an independent risk factor for death, independent from CD4 count, independent from crack positivity, and their mortality is 30% compared to 10% of those without Blastomycosis. So this strongly argue, in my view, for antigen screening in these patients. So what do we have for antigen detection for fungal, HIV-associated fungal infection? As you know, we have crack tests, we have the histo test developed by IMI, and there's a few other tests out there commercially. For Blastomycosis, we have the homebrew MP1P, which we are validating currently prospectively. There's a commercial version of this developed in China by a company in Beijing called Wantai. We are also working with IMI to develop a lateral flow antigen detection assay, and we've just been invited by the NIH to go for a phase 2 SBIR grant to develop this further and scale up. So we're very excited about putting this application together. There's another LFA developed by University of Chiang Mai that look at a bunch of protein, not one particular protein, and that looked to be, this was published in PLOS Pathogen and PLOS Neglected Tropical Disease this year, and it looked to be quite promising, although the study is small. So last couple of slides here, in our ongoing prospective study screening for 3 fungal pathogens, Histo, Crypto, and Talomyces. We've so far only enrolled 191 out of 1,400 sample size. We found Talomyces antigenemia prevalence of 18%, Histo antigen prevalence of 6.8%, and crack antigen of 4.2%. So the clear intervention moving forward is we're pushing very hard to get WHO to be involved, policy to be involved, to screen for these fungal pathogens in patients with advanced HIV disease so that we can provide preemptive therapy to stop disease development in its progression. I don't have a lot of time. I think I run out of time. So I'm going to skip the treatment and sorry about that, and just talk about take-home messages here. First is diagnosis. Do you suspect endemic mycosis with the triad of fever, cytopenia, hepatosplenomegaly in appropriate geographic settings? Antigen and molecular assays are very promising non-culture-based diagnostic that we're pushing very hard forward to change the course of this disease. In terms of treatment, we know from a randomized control trial that M4B induction therapy save lives compared to itraconazole, regardless of disease severity. And the question for the field is, can we do better than that? Can we do better with combination therapy with 5-FC? Now, 5-FCs actually show evidence of in vitro sensitivity for Talomyces. So we're excited to think about putting together a study for that. And then can we do short course of M4B? Do we need to treat with 2 weeks with lots of side effect? So we are working on that as well, pushing forward short course of M4B as what investigator Joe Jarvis did for cryptococcal meningitis that they published, they presented at IAS a couple of weeks ago in the Ambition trial. In terms of prevention, I think there's clear, our data is very clear that antigen screen and treat strategy for primary prophylaxis is a very doable, feasible strategy for this, and it can be very cost effective as well. And the last question is, can we stop secondary prophylaxis with biological suppression and not waiting for CD4 count to rise above a certain level, because we are now doing away with CD4 count? So with that, I'd like to thank you so much for your attention and look forward to our discussion. Thank you.
Thank you, Dr. Thuy. And thank you, Ilan, for absolutely scintillating talks on 2 important endemic mycoses. I mean, I really learned a lot with both the topics. So now we open the session for question and answers, and we have a couple of questions for both of you. So first question I have chosen, which is common for both the diseases, and it's for both of you, that what is the extent of CNS involvement in both the diseases? So Ilan, if you'd like to take first.
Yeah, so far we haven't seen CNS disease in emergent mycosis. Perhaps Nilesh, who I know is an attendee at the session and one of the co-organizers, can maybe provide more updated information about this, but among the close to 100 patients that I have reviewed personally with this diagnosis, none of them have had CNS disease, and when it seemed apparent that they might, there were concurrent diagnoses to explain that manifestation. Similarly, in the literature, there haven't been any cases of CNS involvement.
Okay, so now to you, Dr. Thuy.
Yeah, so in our case series of 513 patients, 21 had CNS infections, and they presented, most of them actually presented with primary CNS manifestation, with headache and confusion. When you look at them, they usually also come in with a whole package of disseminated disease, so they have disease elsewhere in the blood, and it probably, my view is that it's probably it's a spillage into the bloodstream, and it's a hematogenous spread to the CNS. But in these patients, in our case here, particularly the mortality was 80% despite antifungal therapy. So it's very severe. It's probably it's about 1% in our population that we see. So we do see CNS, but it's not a primary, like cryptococcal meningitis. It doesn't have a predilection to go to the CNS, but in the settings of disseminated disease, we do see them. The CSF chemistries are quite unimpressive. It can be bland CSF, but culture positive and with, smear positive as well.
Thank you. So the second question is also common to both the endemic mycosis disease. And the question is like, they want to know that what happens if the patient, are the percentage of patients there who do not present with skin presentation in both the diseases? And do they present only as a pulmonary manifestation, whether a mycomycosis or also a telleromycosis, exclusively pulmonary involvement is seen? Ilan.
Certainly they do present with other symptoms, systemic symptoms and pulmonary disease prior to the development of skin lesions. I think skin lesions are actually in many cases quite a late manifestation, and so the clues to diagnosis prior to that are similar to that which Dr. Lee has highlighted. So certainly we've seen a lot of cytopenias, anemia, sometimes liver enzymopathy, but of course these things are very common in advanced HIV and much more common with other syndemic diseases like tuberculosis. So it can be very difficult in the absence of having something on the surface to biopsy. It is certainly possible that there are other patients that we're missing that don't have cutaneous disease or don't yet have cutaneous disease, but we haven't seen isolated pulmonary disease in, at least not in patients with advanced HIV. Among the cases in the literature of patients with emergent mycosis, there was only one patient that was Emergomyces europaeus from Germany that had what seems like isolated pulmonary disease. But in all other cases, there's been multi-system involvement and primarily affecting the skin.
Okay. So what about telleromycosis, Thuy?
Yeah, so up to 70%, so about 40 to 70% of our patients present with skin lesions. And I agree that most of them tend to present late in the course. By the time they show up with skin lesion, it's quite late. And so it's part of disseminated disease picture rather than a localizing infection. I just saw another question coming in that talked about whether skin lesion be a primary manifestation or they always marker of dissemination. I like to think that it's more likely the second, the latter, that I see more likely. Although there's some cases that I do see where they present with skin lesion alone and they're quite well, and actually, so it probably still a late manifestation of disease, is probably still have disseminated disease, but the host, there's a host component of this that probably the hosts are able to control it well, but it's still in settings of disseminated disease. It doesn't get to the skin through primary inoculation. It's actually inhalation disseminated to reticular endothelial system and then spill out to the bloodstream from the lymph node lymphatic system, lymphatic bed, rather than a primary inoculation issue. And so I think that more likely, if you think about that, pathogenesis is probably occur in settings of dissemination until proven otherwise. And so the reason I presented the non-skin lesion, although most of our patients have skin lesion, I present non-skin lesions cases because that's how they present early in the course, and that's how you wanted to catch them early and think about them proactively and not waiting until the skin lesions showed up. In terms of pulmonary, questions about pulmonary disease, we do see isolated pulmonary disease more frequently in non-HIV patients, although non-HIV patients also present with disseminated disease. And again, I think that has to do with the spectrum of the disease, right? They probably started with acute pulmonary process, and then over time, if it doesn't get diagnosed or catch early, it will eventually disseminate when the host immune system is unable to control infection. So we do see that more in non-HIV patient, but HIV patient, I agree, we tend to just see disseminated disease with pulmonary involvement rather than pulmonary involvement alone.
So coming to non-HIV status, so Ilan, a lot of questions are posed regarding emergomycosis in non-HIV. So what is your experience in non-HIV patients in emergomycosis? Have you seen or reports?
Yeah, so it's considerably less common, but it does occur in the setting of other cell-mediated immune deficiencies, things like organ transplantation. The clinical syndrome seems to be quite similar of disseminated disease, frequently involving skin and presenting with a sepsis-like syndrome. So from what we can tell from the limited number of cases that are in the literature, it does seem to be quite similar.
So one more question from my side, and then the treatment-related questions, Adelia, I'll ask you to ask them, right? So coming from India, right, we see a lot of histoplasmosis cases, and we see histoplasmosis in apparently immunocompetent patients, non-HIV. So the question here is that the blood culture and bone marrow positivity in histoplasmosis, it's quite high in experienced lab, right? So what is the status of blood and bone marrow positivity in these two endemic mycoses? And what culture media both of you will prefer for both the diseases? So Ilan.
So in our series, a number of patients did have positive fungal blood cultures, mycoephilitic blood cultures. About 40% of those who had that test, it seemed to have a similar yield as bone marrow cultures of fungal media. The good news is that it does seem possible to avoid that procedure in patients, and it wasn't common to be able to visualize the fungus on bone marrow aspirates. So I don't think that there's additional yield in patients where fungal blood cultures can be collected from peripheral sites. The best media seems to be standard fungal media. Sabouraud, dextrose, agar, for example, is the one that's most widely used. And then in terms of blood culture bottles, anything with a lysis centrifugation system. So in South Africa, they were largely using the Bactec system with mycoephilitic bottles. Seems to enhance the yield relative to standard blood culture bottles. They do also come positive in some cases with standard blood culture bottles, but considerably less common. I would say less than 10% of cases.
Okay, I'm going to
unmute.
Can you hear me now?
Oh, sorry. I didn't realize. So I just wanted to add, and also, take your advice regarding this, that in histoplasma, we use a BHI, it's a more fastidious, and both of them look quite similar. So for emergomycosis, we can use Sabouraud's for blood culture. So if it grows in the primary blood culture on Sabouraud's, then probably it's not as fastidious as histoplasma is. Can you hear?
I'm sorry, Anna, could you repeat the question, please?
I'm saying that the culture requirement for histoplasma, it is more fastidious. It requires BHI, blood agar for the growth. So if emergomycosis agent grows on Sabouraud's in primary isolation, so that could be one of the difference between these two in the lab. Am I right?
Possibly, I would defer that question to our expert here, Professor Govender, if maybe he wants to answer in the chat.
Okay, so
certainly it can grow in BHI agar, but sabouraud dextrose seems to be sufficient.
I can also add to that, Tellomyces grow readily on the sabouraud agar plate, but in our lab, when we try the yeast peptone dextro, it's actually a much better media for Tellomyces grow as well. And so we see that in crypto, we see that for histo. So I think that we probably haven't tried that, and we keep saying sabouraud agar is a good media, but I think maybe yeast peptones or BHI or other media would be more favorable. In terms of blood culture, there's mycolytic F bottle, there's that would be the appropriate culture media for both histos and all of these fungal pathogens. And I do agree that histo is so hard to grow, with our antigen positive patients, it's so hard to grow. So I think it's much more fastidious than emergomyces or Tellomyces.
Thank you very much. Delia, I share with you.
Okay, let me just then finish off, I think, looking at the time with a few management questions. So you touched both on management of this disease. And what I understood, you have your induction treatment with amphotericin B or ambisome if you have access to that. And then I was wondering, how does the maintenance treatment like? How long do you treat? And can you just point out, how do you monitor effectiveness of the treatment? Can we rely on clinical symptoms? Do we need to reculture, rebiopsy? Thuy, can I start off with you to answer that question?
Sure. So first off, induction therapy is critical. Sorry, I had to skip over that slide, but we really show that induction hit hard, hit early with amphotericin B is so critical because people who get treated with itraconazole front, even though we load them with 3 days, they have much lower time to fungal clearance, and that results in complication, including relapse and iris. So in our trial, people who were treated on amphotericin B, nobody developed iris, for example. So the fact that you start out with potent therapy, you really you have much less likely the probability to develop iris or relapse disease, unless obviously the patient stopped taking antiretroviral therapy, not complying with antifungal therapy. So those are the two key in terms of maintenance and consolidation of maintenance treatment is compliant. The problem with antifungal therapies, you have to keep them on for a long time, right? So the consolidation period is 3 months for Tellomyces, and follow with a maintenance therapy until the CD4 count is reconstituted above 100 for at least 6 months. That's what the guideline says based on very small case series, never been randomized trial to look at that. But if you think about it, for a patient with a CD4 count, for Dr. Schwartz and my patient, they're like 20, it takes them a year to get up to above 100 for more than 6 months. So you're talking 12 months of itraconazole therapy, which is not cheap when you add up to 12 months, and it has toxicity, and there's certain drug-drug interaction issues, right? With efavirenz, for example, rifampicin is another issue. So there's issue with drug-drug interaction and cost. And another issue is PK issue with itraconazole, right? So itraconazole has very poor oral bioavailability. It's only 40% absorbed. And if you're not taking it with a meal or with an acidic stomach, the absorption is less than 20%. So it's nothing. Yeah. And so, we can give the patient itraconazole and think that you're doing well, but you need to tell them that they need to take it after meal or after an acidic drink. That's really critical. Another critical bit is the Pka variability. As you know, itraconazole has a problem. Even though the patient take it appropriately, the level can be very low because of pharmacokinetics issue, pharmacodynamic issue. So it's not great, but that's the only thing we have. And we need to, the key is need to immune reconstitute the patient. Now the challenge is even harder for non-HIV patient, where you can't really remove the immunosuppressive agents in transplant patients. You can't really do that. You're kind of in a hard in a rock place, and there's really no way to tell when to stop. And so recommendation for non-HIV is actually to keep them on, for life, for as long as they're immunosuppressed. And I think, your questions about a way to monitor for histo, we know that antigen tests can be used to say whether the protein is still being released. For antigenemia for Thalassemia, I think that's another way to tell. And in non-HIV patient, if you do the antigen test, and we know it takes 4 months for it to clear, and if it completely clear in a non-HIV patient when they no longer on immunosuppressive regimen, can you stop when the antigen is negative? We don't know that yet. More research needs to be done.
Yeah. Okay, over to you, Ilan.
So I mean, my answer is much less elegant because we really have a lot less information. We don't have a good antigen test at all. We know you can monitor skin lesions, and they seem to resolve fairly quickly over the course of days to weeks. But we've also seen relapses in patients who stop itraconazole even having taken 8 to 10 months. So we do recommend at least a year pending immune reconstitution. As Professor Lee pointed out, a lot of these patients don't immune reconstitute because they present with such a low nadir of their CD4 count. The median CD4 count of 16. So a sizable chunk of these will never get over 100. And so it may not be a practical, in which case eventually you need to stop and then just monitor clinically.
And there is a question about what can we learn from the crypto trials? Would a single high-dose ambisome probably something to be think about in the treatment of a mucormycosis?
So I think we're much more likely to find that answer to Thalassemia, just given the number of patients that are available and recruitable for a clinical trial. I think it would be very difficult to conduct a clinical trial for emergent mycosis, given how sparse the cases are, relatively speaking. I do think that is a plausible role, and certainly hospitalization for 7 to 10 days of deoxycholic amphotericin B is a huge burden to the individual, to their families, to the healthcare system. And so if we can keep those patients out of the hospital without sacrificing efficacy, I think that would be a big deal. And so certainly, I think there is some equipoise on the back of the AMBITION trial.
Yeah. Okay, I'm looking at the clock, and we are 1 minute over. I think we have to stop here. There are some more questions, and obviously an interesting area to address is, should we make a strong case to get posaconazole instead of the itraconazole because of much better absorption, more easy formulations, but we have to leave that for another time. I want to thank you, Thuy and Ilan, again, for really great presentations, really great overview about the more rare fungal infections, probably for some of us, for others more frequently encountered. So thank you, and also thanks to all the attendees for your questions and for your involvement in the interactive cases. Bye for now, and hope to see you on the 3rd of December.
Thank you so much, everyone.
Thank you.